I know. Good morning, everybody. It's nice to see so many faces and familiar faces. I know it's a minute to 10:30. I just thought because we have a lot of content that I would start kind of gradually leading into to bios and let people keep finding their way in. So thank you. I think this is sort of the Medify room for the day, and feel free to join us for as many sessions as work for you. I think, as you know, we're talking in the morning about managing alcohol and opioid use disorder in really the acute care setting. And then we have 2 sessions after lunch talking about RAM care. And then a final session at the end of the day about managing alcohol withdrawal in the community specifically. So welcome. People who already are friends of Medify and people who don't necessarily know Medify. It's my pleasure to introduce our speakers today. I'm Jennifer Wyman. And to my left, we have Katie Dunham, Liz Schuldeis, and Mel Kahan. Katie is a primary care nurse practitioner with a background in global humanitarian aid, emergency nursing, primary care, rapid access addiction medicine, withdrawal management in a community-based live-in setting, and virtual addictions care through the Digital Front Door platform. She's faculty at the University of Toronto Bloomberg School of Nursing and the nursing educator for Medify. And I don't think I introduced Medify, but we are an Ontario-based organization. We are the organizational and clinical hub for the province's rapid access addiction medicine clinics, and in addition, develop all kinds of guidance, educational materials. She is passionate about expanding access to substance-related care through education and optimizing existing pathways through community partnerships. I can attest to all of that. Dr. Mel Kahan is the medical director of Medify. Dr. Kahan has written a number of peer-reviewed articles on addiction and has been a principal or co-principal investigator on several randomized trials and observational studies. He's been extensively involved in policy and advocacy. He has helped write several guidelines on opioid agonist treatment and opioid prescribing for chronic pain, and has co-authored, everything says several, but it should actually be many, handbooks and guidance documents. And his focused interest now is the integration of addiction medicine into primary care, emergency departments, and hospital units. And Dr. Kahan has 5 grandchildren who like to remind him how old he is. And Dr. Elizabeth Schuldeis is an active member of the Department of Emergency Medicine at Queen's Carleton Hospital in Ottawa and a physician at Recovery Care Bell's Corner since 2018. After receiving her medical degree in family medicine residency from Dalhousie in Halifax, Elizabeth returned home to Ottawa to pursue a further residency in emergency medicine. She was very excited to join the staff of the QCH in summer of 2008. She then went on to complete a master's of public health at Johns Hopkins in 2013, gained extra training in substance use health in 2017, and continues to broaden her knowledge in this growing field. Having an interest in health policy and prevention, she works with both the Canadian Association of Emergency Physicians and with Medify. She's also proud to be the medical director of the paramedic programs at Algonquin College. So thank you, everyone, for joining us. We will save lots of time, we hope, for questions at the end of the session. If there's a burning question, I would say please put your hand up, but otherwise, I think we'll answer a lot as we go and save time. So I'll turn it over to you guys.
Thank you so much, Jennifer. Welcome, everyone. Hopefully you can hear us okay. Good morning. Thanks for being here. I'm very honored and grateful to get to present with this group this morning who are more than experts in their field, even though they're too humble to say it. So we're going to dive in and get started with talking about opioid and alcohol-based care, really in the emergency department and somewhat in the inpatient as well. Disclosures. For Mel, honorarium from Indivior for opioid agonist treatment presentations. For myself, honorarium from Indivior for attendance for their advisory meetings as well as educational presentations. And for Elizabeth, no financial disclosures or conflicts of interest. To mitigate bias, we are going to try to use both brand and generic names if we use brand at all, and we will be talking about treatments off-label. We will try to bring it up when those happen. Let us know if you have questions about those. Objectives. So we're going to start with going over the CWA just so we can get out of the way how to monitor for alcohol. We're starting with alcohol first. Then we're going to talk about best practices for alcohol-based care in the emergency department, really focusing on alcohol withdrawal as well as suicidal ideation and attempt. Then we're going to switch over and go to an opioid-based care. So we're going to talk about that specifically for the emergency department, who should go in, who should be cared for, and how, and who should be admitted. Finally, we're going to talk about transitions from care. So if you're not in the hospital or emergency department and thinking you don't know how this relates to you at all of us refer there or have been there, unfortunately. I need to know how to communicate with the emergency department and to decide who goes where. So we'll dive into that as well. Huge agenda, so let's jump in. So management of alcohol withdrawal in the emergency department. Just to say up front, thank you so much, Jennifer, for introducing Medify and the toolkits. If you haven't been to the website, you can use this QR code. You can explore the website. There's tons of resources. There are a number of them that are specific to the emergency department, and a toolkit, in our mind anyways, just as a grouping of resources that are all kind of related. There is a toolkit for alcohol-related presentations to the emergency department. You'll find it at this QR code and link. It has order sets. It's got prescription templates, it has recommendations, it has one-pagers, it has patient handouts. So hopefully anything that you would need if you were looking for more information. And a lot of this presentation is coming directly from those recommendations as well. And the amazing group of authors and reviewers that helped us to develop it. Starting with the CWA. So this is the Clinical Institute Withdrawal Assessment. I was so excited to see that there are other presentations and posters on this at the conference. So hopefully people get to go and see those as well. So the Clinical Institute for Withdrawal Assessment for Alcohol revised. Specifically, it's a scale for measuring alcohol withdrawal severity, not for diagnosing it. It has to be diagnosed first, and then you can measure the severity of it. It is a 10-item scale. It's typically measured every 1 to 2 hours, I would say. A score of 10 or more typically indicates treatment is needed. That's going to be unit dependent. Some facilities might say 8 or greater requires treatment. I'm not that fussy. Looking for an 8 to 10 or greater means you need to start to look for treatment for alcohol withdrawal. Treatment is typically completed when the score is less than 10 on 2 consecutive occasions. Again, facility dependent. I'm not here saying that has to be that way. It can be less than 8. It could be less than 10. It could be twice. It could be 3 times. You need a couple consistent scores that are low and staying low before you're planning for discharge from the emergency department or any facility. The CWA scoring in general is kind of rated as a mild is going to be less than 10, a moderate withdrawal is going to be somewhere between 10 and 19, and a severe withdrawal you're going to be scoring greater than 20 or 20 or greater. It's not a perfect scale, and I'm excited to see the other presentations on this because I'm sure if anyone's used it or around it, they know it's not perfect. There's many limitations to the CWA itself. It's very subjective. The clients will be telling you their scoring along the way. Clients are experts in their own care path, so it has pros in the clients telling you the score. But you can get a lot of false positives. If someone is naturally anxious, which they're going to be if they're coming in for treatment that they didn't want to have to do in the first place, you're going to be a higher likelihood for positives there. Of course, if they're in psychosis, concurrent substance use is very common, so that could be a concern as well. Anyone with an essential tremor or any other type of tremor that isn't alcohol withdrawal associated is going to have difficulty scoring on this. Any kind of cerebellar disease, of course, any delirium that's not alcohol related, again, will score positive. Febrile illness will make it very difficult to complete the CWA at all. And anyone that's seeking medication, you can answer questions to score positive using the CWA. There are also false negatives. If there's any kind of language barrier between the person providing the scale and the person answering it, it's not going to be easy to complete. Any kind of cognitive delay, any dementia, impaired consciousness, or lower education level is going to result in potential false negatives. So this is not perfect by any means, and it can be time consuming, and there can be poor inter-rater reliability if you are not consistently trained in it. So it's very important that you have everyone in a facility that's doing it is doing it consistently and doing it the same, which is where I think this is so exciting. So we were very excited to partner, I guess, with CAMH, who produced this accompanying e-learning module specific for the CWA. So it's free. I love free things. That's amazing. It's publicly accessible. Anyone can go to this website and get access to it. And it goes over everything to do with alcohol, how to diagnose withdrawal, when to care about withdrawal. And it goes through case examples of how to score a CWA, and it comes with a certification. So any of your careers that need some kind of certification to show your college, have your organization, have everyone complete this, and at least you'll be on the same page of how you're going about completing it. Can't say enough how much I think this is so fantastic to have for everyone, honestly, across Canada. They do leave it vague enough that you could implement it into your own facility in terms of cutoff scores for CWA, if that's what you're wondering about for treatment. A lot of the things that you're going to find in that training program and in our withdrawal guide are these tips and tricks for CWA. So we're going to go through a couple of them here. Randomly just wondering, how many nurses are there in the room? Like RNs or RPNs? Woo, go us. Okay, cool. So this may be more specific. Anyone can do the CWA, obviously, but it does get assigned a lot to the RNs or RPNs of the group. Couple tips: nausea and vomiting. Although this is a subjective score, you do not have to rate exactly what they tell you. If they say, I am so nauseous, I'm vomiting all the time, but they just ate a big breakfast, they're sitting there comfortably, do not put them as a 7 on nausea and vomiting. You can make a clinical judgment and change that score. And that's a lot of what I'm going to say for these tips and tricks. So we'll go over the tremor in a little bit, actually. For sweating, have they been sweating in front of you right now? Have they been reporting sweating on and off? This is paroxysmal sweating, actually. Are they anxious more than their baseline? A lot of patients will just tell you, of course, I'm anxious. But if you ask them if they're always anxious, they will also say yes. So can you see that it's more than their typical anxiety? The headache does not have to be just headache, actually. Are you feeling fullness in the head? Are you feeling like there's a pressure? Are you uncomfortable? All would score for a headache as well. For agitation, you can use a lot of the signs in front of you. So watch the patient. Are they restless? Are they agitated? Are they moving back and forth? Are they able to sit comfortably in their chair or their bed? For anything that's the auditory, the visual, the tactile hallucinations, again, they don't have to be full-on hallucinations like you would have seeing something or hearing something. Are they more sensitive to light? Are they more sensitive to sound? Are they bothered by these things? Are they feeling uncomfortable in their skin? Those kind of things would also score positive. So it doesn't mean that someone's just a positive or a negative. There's a reason there's a scale for this. And orientation, of course. So I think one of the big tips that is different from how a lot of people were trained with the CWA and specifically for the emergency department. I was an emergency department nurse, and one of the things that's kind of a great thing to use in the emerge is if someone's fallen asleep, great, they're healthy enough, they're feeling well enough to fall asleep. We like to leave sleeping people sleeping. It gives us a little bit of time to complete other tasks. Unfortunately for alcohol withdrawal, you can't do that. Alcohol withdrawal can and will worsen while someone is sleeping. You do actually have to wake the patient up and complete the CWA to see if they need a dose or not, even if they were able to fall asleep. So unfortunately, that one is there. Tremor can be very difficult if you're not commonly assessing this, but it is very unique for alcohol withdrawal, which is nice. It's not a resting tremor, so you do have to have them do something. It is postural, so against gravity, and it is an intention tremor, so action, doing something. So typically the request would be holding your arms out in front of you. My hands are shaking so you can see. And a bit of spreading your fingers. And if there's a tremor there, you can have them do a task if you're not quite sure, like drinking a bottle of water, or just putting your fingertips on theirs if it's a really fine tremor will help you as well. The other thing about the tremor is it doesn't diminish. If you're curious if someone is going to be trying to fake it to get some kind of medication, they won't be able to hold their fake tremor forever. If you have them stay like this, you will have the same tremor consistently. It will not go away. That tremor will be consistent with alcohol withdrawal. Vitals are not actually a part of the CWA 10 questions, but they are vital in making sure you're diagnosing the alcohol withdrawal appropriately. There are definitive signs of alcohol withdrawal, and a lot of those are the vitals. So those really high systolic and diastolic blood pressures, greater than 180, greater than 110. Febrile doesn't have to be like a 39-40 to be febrile. It could be anything greater than 37.5, honestly. You would be counting as a febrile concern for alcohol withdrawal association with an hyperactivity. And the heart rate that's elevated, typically greater than 120, because anxiety will be there as well. I've listed a bunch of other ones that are definitive signs for severe withdrawal. Most of them are obvious. So arrhythmias, profuse sweating, you will see repeat vomiting, the tremor, the hallucinations, the psychomotor agitation where they can't sit still, the confusion, disorientation, delusions, obviously seizures, and delirium tremens. If you are just not a CWA person or your unit doesn't use CWA, there are other options. They're not as well studied or validated as the CWA, but from the studies that are there, they do tend to hold up pretty well. One of those is the SHOT, which measures sweating, hallucinations, orientation, and tremor, trying to remove the subjectivity of the questions. One of them is the BAWS, or the Brief Alcohol Withdrawal Scale, which only adds on agitation as an extra measure. So they can be quicker to complete. Really, they're quicker to complete, which is nice and less subjective. I did give an example of the SHOT here, but it's pretty basic in terms of how you would want to complete it if you want to go forward with that. And we're going to jump over to treatment for Dr. Khan.
Thank you, Katie. I'm going to talk first about treatment of alcohol withdrawal. One thing is clear from our clinical experience and research is that alcohol withdrawal tends to be dramatically undertreated in many emergency departments with small unit doses and long intervals between doses. This is just one study illustrating this. 450 people with, it's an observational study with alcohol withdrawal. 230 received benzos only. And in their entire stay in the emerge, they only received the equivalent of 6 milligrams of lorazepam versus the group that received phenobarb plus lorazepam. They had over 4 times as much the dose. They had 26 to 28 milligrams. And here you see a dramatic difference in 3-day return rate, 25% for the benzo group and 10% for the phenobarb slash benzo group. So this illustrates that there's a lot of improvement to be made in management of alcohol withdrawal. Symptom-triggered benzodiazepine treatment is pretty well universally considered the treatment of choice for alcohol withdrawal. There are a number of randomized trials, not so much done in an ED setting, but in other settings showing that symptom-triggered treatment reduces the length of stay and reduces complications. And in symptom-triggered treatment, you give very high unit doses because the patients are very cross-tolerant to sedatives. So you can give 20 milligrams of diazepam or up to 4 milligrams of lorazepam at a time, and they're dispensed every 1 to 2 hours according to the severity scale, alcohol withdrawal severity scale, such as the CWA. So this treats withdrawal early and aggressively and completely, reducing length of stay and reducing return rates because the patient doesn't have to return because of untreated withdrawal. And narrative reviews and observational studies have recommended that symptom-triggered treatment be used in an ED setting. Loading doses have been shown to be effective in preventing complications of withdrawal, particularly seizures, but also delirium tremens. You want to start the loading dose not when the patient is intoxicated, but when they're no longer intoxicated, maybe they're starting to go into early withdrawal, and there should be at least 6 hours that have elapsed between the last drink and the dose. So this is dispensing 20 milligrams every hour for full dose or lorazepam, regardless of the CWA score. And after that, you continue with symptom-triggered treatment. Choice of agent, diazepam is generally preferred because it's got an extremely long duration of action, up to 5 days with its active metabolites, so that can help cover the withdrawal symptoms when the patient is discharged. Lorazepam has a shorter duration of action and isn't metabolized to active metabolites, so it's preferred for patients who may be at high risk for benzodiazepine toxicity, that is, patients with cirrhosis of the liver who have trouble metabolizing diazepam, or people with respiratory impairment, or those who are on high doses of opiates such as methadone, or the elderly. Other aspects of care, just to mention very quickly, and again, as Katie and Jennifer mentioned, these are all contained in the Alcohol Use Disorder Toolkit. Administer thiamine routinely. For moderate to severe withdrawal, you want to check for electrolyte imbalances that can trigger arrhythmias, such as sodium, potassium, chloride, magnesium, etc. We do recommend checking liver transaminases and tests of liver functions, such as INR and platelets and albumin, because that will determine your choice of agent. For severe withdrawal and DTs, we do recommend an ECG and possibly cardiac monitoring. Severe withdrawal is associated with prolonged QT interval, which can result in torsade. And the other thing is that the QT interval resolves and goes back to normal with treatment. So management of severe withdrawal, this is the one that causes the complications, the seizures, the DTs, etc. This would be people with a very high CWA score, above 20. They have a marked tremor, agitation, tachycardia, and so on. We do recommend intravenous dosing because it's much faster acting, 10 milligrams of diazepam or 2 milligrams of lorazepam every 10 minutes until the patient starts to respond, and at that point you may switch back to oral or continue with intravenous. If the patient is in moderate withdrawal and they're starting to verge into severe withdrawal and they're not responding to oral doses, another option is to double the oral dose. These are patients who are resistant to benzodiazepines, and sometimes giving them a higher dose or a more frequent dose will actually turn things around. Phenobarb for severe withdrawal, there is good evidence that phenobarb oral or intravenous in a supervised setting like ICU, if the patient continues to worsen despite IV or double oral dosing, consider phenobarb in addition to lorazepam. In an emerge setting, that might be 30 to 90 milligrams TID. And if the patient is still in withdrawal, despite that, they should probably be admitted to a monitored bed. Now, there is a controversy about phenobarb for moderate withdrawal. That is withdrawal that hasn't gotten a huge benzo dose yet, where
Keep going. I'm just going to adjust the mic. It's a little hard to hear you.
sorry. They haven't yet. They're not in terrible tremors or sweating. They're not confused or anything like that. And that is recommended by GRACE 4, which was a systematic review of a big group in United States of emergency clinicians. They recommended phenobarb for moderate withdrawal. I would say one advantage of phenobarb is that you don't have to give it every hour or two, so it's a lot easier in that sense. But we have to remember the history. The phenobarb or barbiturates were commonly used back in the 50s and 60s, and there were many deaths, accidental overdose deaths associated with barbiturates then, and the most common reason for those overdose deaths was combining barbiturates with alcohol. So we are talking about giving phenobarb to people who are going to be discharged, and some of them, many of them perhaps, will go back to drinking. So that is a real concern about the routine use of phenobarb. And furthermore, evidence does not yet support phenobarb for moderate withdrawal. It does support it for severe withdrawal, but moderate withdrawal is meaning operationally the clinician doesn't feel the patient needs to be admitted to hospital. Controlled trials have not found phenobarb superior to benzodiazepines. And in these controlled trials, the patients were in the barbiturate benzo group were given adequate doses of benzos. So adequate doses of benzo seem to be as good as phenobarb for moderate withdrawal. And the observational studies, they tended to have patients who were given very low doses of benzos compared to the phenobarb. Delirium tremens is severe withdrawal plus signs of delirium, agitated delirium, confusion, disorientation, delusions, hallucinations. Patients are at somewhat risk of dying of cardiac arrhythmias, torsade de pointes, and they're also at risk of harm because they may leave the emergency department and put themselves at risk. You can prevent DTs. I think there's good evidence that aggressive benzodiazepine loading and symptom-triggered treatment can prevent DTs. If the patient isn't responding to this, you can accelerate treatment with intravenous dosing and with oral dosing. And you also want to do cardiac monitoring and correct electrolyte imbalances. If the patient is very agitated and delusional, and chemical restraints, that is, benzos, are not sufficient, you may need physical restraints. Be cautious with antipsychotics. They can lower the seizure threshold, and they can also prolong QT intervals. So use them with caution and try and rely on the benzos or phenobarb. And admit to the hospital, obviously, if the patient isn't responding. Discharge medications for withdrawal. We'll be talking about anti-craving medications in a minute, but if the patient is in mild withdrawal on discharge and you feel they may still need pharmacotherapy, you can consider either tapering smaller doses of benzos, such as 10 milligrams QID of diazepam or lorazepam, 2 milligrams QID, and then cut down by 1 pill a day. or gabapentin 300 milligrams TID. Actually, gabapentin is probably preferred because there is evidence that it's effective in mild withdrawal. It's not as good as benzos for moderate to severe withdrawal, though. It's less sedating than benzos, and it can be used as an ongoing anti-craving medication. There is good evidence that it reduces subacute withdrawal. I'm going to talk about suicide. Suicidal ideation. Suicide is a major cause of death among younger patients with alcohol use disorder. There's a high risk of suicide with people with AUD, especially if they're frequent visitors to the emergency. There is sort of equivocal evidence about treatment of AUD. It certainly reduces short-term risk of suicide. Long-term risk, it almost certainly does, but we're just not sure yet. Reviews have consistently recommended that patients who present to the ED are offered both immediate access or prompt access to addiction treatment as well as mental health treatment. And yet the common scenario is patients come in intoxicated and suicidal. By the time they see the psychiatrist, they're no longer intoxicated and they deny suicidal ideation, so they're discharged perhaps with a referral to a mental health clinic. The problem here is that patients who are suicidal when intoxicated and not suicidal when not intoxicated are at very high risk of ultimately completing suicide when they are intoxicated. So this is still a very concerning scenario. And what we're recommending is that even if the suicidal ideation resolves, that you prescribe an anti-craving medication, you connect patients with a peer worker in the emergency or other addiction service worker if possible, and strongly encourage rapid attendance at a low-barrier addiction clinic. In other words, like any other patient with alcohol use disorder, but more urgency with someone who presents with suicidal ideation. You might consider admission to withdrawal management or some other sort of facility to ensure a strong connection to treatment. If there is an underlying mood disorder suspected, you may consider an SSRI or outpatient referral to mental health. And that is a very quick review for me. And now I'm going to turn it over to Elizabeth.
Hi, everyone. Can you hear me in the back? Okay, you're okay? Okay, thank you. So this is my first CSAM in person, and I'm really thrilled to be here. I'm used to going to emergency medicine conferences. There are far few Patagonia vests and cargo pants here. You all look terrific, and I'm looking around the room, and I see a lot of real experts in this area. So I am intimidated. But we'll get through this together, and then hopefully there's time for questions. And there's such experts in the room. I hope we can have some conversation after. So as Dr. Wyman mentioned, I'm a full-time emergency doctor. I've been an emergency doctor since 2007. Wow, it's like now a long time ago. I look around for like the more adultier adult, and that's me. And I've been doing addiction medicine since about 2018, 2017. I started my training. So these issues have become really important in my clinical practice, both in my addiction practice, but also in my emerge practice. And I hope that I brought some of my substance use care practice into my emergency department. Just a very quick anecdote. I got a text last night just before I was heading out for dinner with some colleagues that said, "Any tips for prescribing buprenorphine in the emergency department?" And normally I just answer the phone and answer my colleagues. Instead, I just sent him the Medify website and said, "Any questions, let me know." And I didn't hear back, and apparently things went really well. So there are so many resources there to pass on to your colleagues, even if these are things you know very well. So just quickly, my objectives. We're going to look at management of withdrawal presentations, presentations of patients already on OAT, acute pain management for someone on OAT, and special considerations for prescribed alternatives, formerly known as safe supply. And we will, of course, be discussing off-label use of buprenorphine. So I wanted to first go over 3 organizations' guidelines really quickly of why we should do this. Really, this should be standard of care. So the Canadian Association of Emergency Physicians came out with guidelines. I was one of the authors on these, and we're looking to redo these guidelines in the coming year. So we should be using case finding strategies to find patients with opioid and other substance use disorders in the emergency department. We should be initiating first-line opioid agonist treatment in patients with OUD in the emergency department. We should provide overdose education and naloxone distribution. We should engage in harm reduction, and we should improve transition to cares and social stabilization. So these are things that come from our national organization in emergency medicine of things that should be our standard of care. And these guidelines came out now nearly 5 years ago. I have a meeting next Tuesday to sort of redo these and look at the next iteration. You look at the BCCSU guidelines, we know that individuals with OUD have high rates of emergency department utilization. For those of us who work in the emergency department, we know that. These rates of utilization suggest that we might have an opportunity. So rather than looking at this as a barrier or I don't know what to do with these patients, this is an opportunity for us to engage these patients in care. There's also a small but growing body of evidence that if you engage patients in treatment in the acute care setting, they're more likely to continue. So if you start their treatment, engage them in treatment, they're more likely to carry on rather than if you just give them a card to, go see so-and-so in a week. If they choose to engage in OAT in the emergency department or in an acute care setting, or if they don't, we should still engage in all those other harm reduction and other discussions that go along with opioid use disorder. So provision of take-home naloxone, referral to community resources, referral to support services, and education on harm reduction. And then the 2018, so the previous iteration of the CRISM guidelines, initiate opioid agonist treatment with buprenorphine whenever feasible. That reduces the risk of toxicity, morbidity, and death, and facilitates safer take-home dosing. If individuals don't respond to buprenorphine naloxone, then consider methadone or consider SROM. So I wanted to just highlight these as these are three, big players and guidelines for acute care management of patients with opioid use disorder in Canada, and they're all sort of saying the same thing, that this is something we should be doing in the acute care setting, and in many places it's still not happening. So why do we suggest that buprenorphine is the right medication to start in an acute care setting? Lower risk of overdose, fewer drug interactions, lower cardiac risks, lower risk of interaction or overdose with alcohol and benzos, shorter time to stabilization, and doesn't require prolonged daily observation in pharmacies. So this is a good medication, which many of us already know. We know that it's safe. If you look at it compared with other opioids, it's safe. And it's a long-acting partial opioid agonist with a ceiling effect. So it has a high affinity, slow dissociation. So you know that you're going to give a patient a medication that's going to last a long time and provide them some relief. We can initiate this in many different ways. And I know I am literally speaking to experts on this, so I'm going to review these things quite quickly. But in an acute care setting, we can do a traditional start. We could do a home start. There are areas where microdosing might be appropriate, and we can do macrodosing as well, which is something we'll get into in a little bit more detail. I think many of us are familiar with the COWS score. This is available, of course, on the Medify website. It's also available on MD Calc, on many of our other apps and resources. It might not be something that those of us who are doing this on a daily in and out basis use in detail, but it's for our allied staff. They feel really secure in knowing that there's a score that they can use that can help them to initiate treatment or to alert the staff like, hey doc, this person's COWS is still super high. I don't know what to do. And that gives them an objective tool. So I think this is important that we keep using. So these are the considerations when you're starting someone on buprenorphine, but I want to challenge some of them a little bit. So certainly patients should receive counseling about the goals and expectations of their treatment. They should understand that they'll need daily dispensing, of course, initially. They should understand that it's an opioid, that that's what we're prescribing them, and that rapid discontinuation can result in withdrawal. These are things that I think we should tell them all. Patients should have a clinic provider available for follow-up care and a pharmacy identified. That can be a challenge in many places. So that's something that I think when we talk about transitions to care, we can talk more about. One of the emergency medicine physicians that I really admire a lot in the US is a guy by the name of Ruben Strayer. He works in Brooklyn. He said, even if you're prescribing buprenorphine to someone for 2 days and they don't have access to follow-up care after that, you're still providing them with 2 days of life-saving medication that decreases their risk of harm. It decreases the chaos in their life for those 2 days, and it's not a reason to not prescribe it. That said, here in Canada, we should ideally be able to have access to outpatient care after the fact, and we can talk more about that. They should have a health card. Now in Ontario, once again, everybody has to have a health card. But again, that shouldn't be a barrier to care. And we should make sure that patients understand their instructions. So a traditional initiation, I think we all know this, you need a COWS of greater than 13 and varying degrees of how long it's been since your last opioid. So 12 hours from short-acting opioid, 18 hours from intermediate, and the long-acting, like 72 hours, maybe less. It's tricky to know, but these are guidelines to keep in the back of your mind. What's your drug of choice? What have you been using? And then you can start to think about whether you can do a traditional start, 2 milligrams. 20 minutes later, you'll do another 2 milligrams, maybe send them home with something if you're doing it outpatient, or similar, but in the emergency department. So Medify, we have order sets. So you can, again, text your colleagues at 11 p.m. and be like, here you go, here's the order set. But they're also really useful to pull up to show your colleagues. So if you're a physician or if you're a nurse champion of this, and you can pull these up and say, here, look, this is what I think we should be doing. So this is the order set for buprenorphine, traditional buprenorphine initiation. And then there's some discharge orders, which I think are really terrific. And it gives a good checklist of what to make sure the patient knows before they're discharged. So again, we know that the withdrawal can set in anywhere from like 12 hours to 72 hours, and we're going to want to tailor our treatment based on that timing. So we talked about this. In the emergency department, we're going to reassess after an hour. We're going to offer another 2 to 4 milligrams if the symptoms are improving, but not resolved. And then we're going to discharge them with a prescription for the remainder of the day and until follow-up. So follow-up could be, 7 days from now. It could be a long time. That's okay. This is safe to do, and it's important if you're doing this in the emergency department that you know what pharmacy they're going to and that the pharmacy is on board as well, and we can talk a little bit more about that. I think many of us prescribing this medication in an acute care setting live in fear of precipitated withdrawal, right? I think when many of us were going through our training, that's what we heard of, and we were like, I can't do this. Someone's going to go in precipitated withdrawal, and it's going to be horrible. But we now have ways to fix that. So precipitated withdrawal is really just that the buprenorphine comes in, it knocks all the opioid off the receptor, and then patients go into a withdrawal. So if they have markedly worsening withdrawal symptoms after the first buprenorphine dose, and it's just not improving, they're probably in precipitated withdrawal. So you can use things like ondansetron, clonidine, other symptomatic treatment, or if you're in a monitored setting, you could just offer higher doses of buprenorphine. So you could look to do what we will talk about in a few minutes is more macro dosing. And I just added on the bottom, cabridge.org is the organization in California that started this. It's also used a lot up in Timmins. I've done it myself in the emergency department, and it's incredibly satisfying to watch someone get well before your eyes. So a home start. So this may be appropriate for patients with previous experience. They're like, doc, yeah, I think I'd want to restart that. I'm not quite there yet, but I've done this before. I know that this works for me. I know when I'm in withdrawal. There can be some barriers to this. So, if they're in insufficient withdrawal, if your emerge wait times are like 2 hours and you've seen the patient too quick, has that happened to anybody in the last 12 months? Like no, right? No. Patients are in 72 hours of withdrawal by the time they have their first physician assessment. I'm just kidding. They don't have any other substance use disorder. They're going back to a stable environment, or they're at least, housed and have access to medications. So again, there's an order set, and they can use the SAOS, which is the Subjective Opioid Withdrawal Scale, and they can do that every 2 hours. But what I like better is this, and this is available on the Medify website as well. This is, when am I ready to start Suboxone? So if you check 5 of these boxes of your withdrawal symptoms, then you're ready to start. Most patients, for those of us who provide care, most patients, if you say, are you in withdrawal? They'll be like, not yet, or yeah, I'm getting there. I think I will be by tonight. But this gives them a more objective tool for how to do this. And then what's my plan? So for those of us who have worked in acute care for a long time, it's like their asthma action plan, but it's for Suboxone. So what's my plan? I'm going to take this much at this time and sort of go from there. And then it gives them a little chart to record their doses. So then when they follow up with care, they can present this to their NP or PA or physician and say, this is what I did, to give you a better idea of what their dosing has looked like. Just very briefly on microdosing. So I think many of us have been using microdosing within our clinical practices. It's when you give a very small amount of buprenorphine to sort of build up the amount while they are still taking an opioid. This is best used not in the emergency department, but may be very useful if you have an admitted patient that you're looking to switch over. So you have an admitted patient who's come into you, they're on a whole bunch of opioid that's been prescribed, but you're realizing that maybe they have some opioid use disorder. They're interested in switching to buprenorphine. So maybe you'll use this while they're admitted. So appropriate for patients who can't tolerate withdrawal symptoms, shouldn't undergo withdrawal for medical reasons, have continued opioid use, and want to avoid that terror of precipitated withdrawal. And it can be taken while the opioid continues. So this is all very, very useful for patients on prescribed opioids. I've had lots of success for patients with chronic pain who have wanted to switch over and have been very, very successful. I think many of us have. And then you can use it to cross taper their medication as well. So if you look, I really like this graphic. So the blue, I hope this shows up well. The blue is their current opioid and the orange is the buprenorphine. So you see the orange going through day by day. Gradually, there's more and more orange occupying their receptor. And then the patient sort of just stops their existing opioid. So again, not necessarily something super appropriate in the emergency department, maybe with the right patient with really close follow-up, someone who you can connect with another addiction provider the next day. But for an inpatient, this might be ideal. Then I wanted to talk about macrodosing. So macrodosing is when you give large amounts of buprenorphine right off the bat, rather than a traditional start, a home start, or microdosing. You can do this post-naloxone. So for those of us who work in emergency medicine, we often get patients who've come in, they're feeling miserable, they've had 2 or 3 doses of naloxone to save their life from our pre-hospital colleagues, from paramedics. And then we're looking, okay, what do we do with this person now? Are we just going to treat their symptoms and discharge them back? Or could we engage them in treatment and maybe get their symptoms better with something that could start them on a treatment path with buprenorphine? So initially there were case reports of this, and now it's been a little bit better studied. So I'll show you one of the studies in a moment, but reduces the risk of precipitated withdrawal and achieves a therapeutic dose much more rapidly. So it's not even like a traditional start where you're giving someone a little bit less than a therapeutic dose on their first day. They're right up to a therapeutic dose right away. So I like this graphic also. So you give them 2 milligrams, they're not, like nothing's really happened. Then between 2 and 8 milligrams, you have that displacement, right? Where they're still really feeling miserable and crummy, but then you get up to displacement and agonism. So you get up to the levels of buprenorphine where the patient's feeling really much better. Then you're also much better able to engage them in treatment. So you can do this in the ED setting, cows greater than 5, 8 to 16 milligrams at a time. But you're going to do something different than with the traditional start. You're going to repeat those 8 milligrams every hour until they're feeling better. And it's really rare to have any other adverse effects from this. Most patients do really well. So in a lot of the precipitated withdrawal literature right now, they'll say if someone's having precipitated withdrawal, just give more. They're just buprenorphine deficient. And you can certainly do this in an ambulatory setting. It's a little bit easier and a little bit more recommended if you're doing it in an observed setting. Max is 24 milligrams as an outpatient, 32 if you're monitoring them in an inpatient. I took this right from the study that was done on this, and it's just a flow chart that tells you exactly how to do this. All of these slides are available on the Medify website. So, and this was part of a case series that looked at this. Patient given naloxone, then immediately given buprenorphine, Some of them needed an additional naloxone because there's still, there's still a lot of whatever it is they've taken that's floating around. But then ultimately, all 3 of these patients were able to be discharged with their buprenorphine on board after 7 hours. If you see this graph, I find a bit confusing, but if you see this as the end result is on the right, which is discharge. So within 4 hours, these 2 patients who'd be given naloxone at time 0, they were each given 8 milligrams of buprenorphine in sequence, and both were able to be discharged from the hospital. So it just shows that this can get rid of their symptoms quite quickly and gets them on their treatment medication right away. Part of the barriers I found when I was first in practice with buprenorphine is, gosh, I can't get these people feeling well right away. And you can imagine how someone wouldn't engage in treatment if they're not going to feel well right away. They're like, oh, this seems like a lot of work. So this is a really positive thing. There are some barriers with initiating this post-naloxone. It's not something that's done completely routinely now across Canada. There are some ethical considerations. You're starting someone on treatment that they're in the throes of in this terrible withdrawal, but you're like, okay, well, I can offer you this treatment. I think there's ways to do this that you can sort of overcome those barriers. This is someone that you're going to want to make sure that they have access to good follow-up afterwards, but they're going to feel so much better if you can get them on a therapeutic dose right away. Existing OAT patients in the emergency department, this is really important to mention. I don't know if any of you work in hospitals that still can't get methadone brought up to the emergency department. This has been a barrier across Canada, around the world. Now that patients are waiting so long in the emergency department, which is both embarrassing and a failure of our healthcare system, you see patients waiting so long that then they've missed their methadone. So they come in the evening, they don't get seen till the morning. They're waiting for a CT scan. They're waiting for whatever, and they're at risk of leaving with their acute medical issue because they can't get their OAT. So they're right from the CAPE guidelines. We should be making sure that patients get their usual doses of their medication, even if it means a pharmacist has to come in from home, even if it means you're disrupting the norms of your hospital. These patients need to be given their medication. In terms of pain control in the acute setting, this is something that I get asked a lot by my patients. I don't know about you guys, but I get asked a lot about this by dentists of what to do with patients for acute pain who are already on OAT. So we know that these patients should continue their buprenorphine or their methadone or their SROM, whatever it is they're on. And continuing this after surgery may decrease their need for additional opioids. We also know that they're opioid tolerant and they may need higher doses of opioid agonists or other opioids for pain control as compared with other patients who don't have OUD. And ineffective management of acute pain can lead to disengagement in care. So patients on methadone, they come in for a surgical procedure, their pain isn't adequately managed. They're like, you know what, forget it. I'm going to quit all of this. And I can understand how that can happen. So it's really important as a community of practice that we advocate for our patients. We speak to anesthesia, we speak to our dental colleagues, we speak to the surgeons to make sure pain is being adequately managed. We also know now that buprenorphine, we used to think that it wasn't so good for pain control. Now a split dose of buprenorphine can be really quite effective for pain control. So if you have a patient who's going in for surgery who now takes their medication all at once in the morning, maybe it's best to split their dose before they go in for an elective surgery, or you might want to look at adding additional buprenorphine. And this has been studied, Journal of Pain Research just from not that long ago. And the same, that buprenorphine is now used to treat pain. So in patients with chronic pain who you're looking to switch off some of their existing opioid treatment, they may do really well with buprenorphine. I don't know about all of you, but I get asked a lot, well, is this going to help my pain? Is my pain still going to be controlled? And oftentimes the answer is yes, and now this has been studied. So very briefly, my last slide, Dr. Wyman just gave me the time. So yes, my last slide. Prescribed alternatives, so formerly safer supply. It's really important that we talk about this. For those of you who have prescribed alternatives prescribed in your communities, if you practice in an acute care setting, you need to know what to do with these patients. It can be very, very challenging. So we need to be aware of what's prescribed in our communities. We need to be aware of what patients are getting. We need to make sure that we can estimate the patient's opioid tolerance the same as we would do with any other opioid. So we have to look at everything they're prescribed, but then engage the patient in a conversation. How much of this are you actually taking? We know that diversion can be an issue. Are you sharing this with friends and family? Are you diverting this? How much are you actually taking? Because I don't want to give you the full dose that's prescribed. There's suggestion that we maybe start with prescribing in an inpatient setting half of what they're actually prescribed. I think it's worth a conversation with the patient. In my experience, patients who come into the emergency department are quite forthcoming about how much they're actually taking because they understand the risks. So we should make sure that we're aware of what's going on in our community around us. And now we'll talk about transitions. I will transition to Katie talking about transitions.
Beautiful. Thank you, Elizabeth. And Jennifer, you can cut me off too if I go too long. So to wrap it up, hopefully some more practical tips for how to talk to your emergency department if you're sending in, or what to do if you're the emerge sending out. So this is a list of how to communicate with the ED that actually came from emergency department clinicians, nurses and physicians and NPs that work there, and this is their preference in terms of how do you communicate. So if you are in any kind of outpatient clinic and you're sending someone in, what do they actually like and when are you annoying them or doing too much? They do like the written letters, but they did suggest that if you're going to write up a letter, a summary of what's going on with the patient, give it to the patient as well as just faxing it in. If you've ever been in an emerge as a patient or a clinician, it's busy. It's so much is going on there. A fax will get lost or just won't be received at all. So give it to the patient, email or printed, so they can actually show, yes, my clinician sent this in as well. If you did call and attempt to speak with someone in the emerge, good for you, points for you, first of all, but then also put that person's name on the letter when you're sending it in, so they are kind of flagged to give that letter to that person, so they remember the conversation that you had on the phone, because the patient won't show up there within the hour even typically, and this could be a while later with how many patients they've seen in between. Highlights to include in the information you're sharing with the emergency department. They do want to know how the patient will be presenting. Are they going to show up in severe withdrawal? Were they already in severe withdrawal when you assessed them? And what did you do, if anything, to manage that along the way? Have they required higher doses in the past? And what kind of treatment did they get, if any, in the office or however you assessed them? Background, keep it brief, but important for the emergency department clinician to know is, how did you assess the person? Was this actually in person? Did you just talk to them on the phone? Was it a telemedicine appointment that you had? When was their last drink that they're reporting consumed? Obviously, from that assessment into the emergency department, there could be more, and the significant medical history. So these are things like, were they hospitalized in the past for alcohol withdrawal? Have they had seizures related to alcohol withdrawal? Have they had delirium tremens? And of course, the medications that they're on as well. Last thing, and maybe the most important, is when can they actually follow up outpatient? We do not want to bombard emergency department with more than what they need to do. They are needed. We need them to provide emergency treatments for patients that are at risk of bad things happening in alcohol withdrawal, but we don't need them to stay there for long periods of time. And we really hope that they don't need to be admitted. So when, if you're an addictions outpatient clinic, when are you open? What are your hours? How can you be contacted? If they're going to a withdrawal management service afterwards, is their bed available? Who can they contact there? So make sure the emerge knows what's going on afterwards. You can really help prepare the discharge before the patient even goes in. This is just an example write-up of really what I just said. So please see this patient for acute alcohol withdrawal management. They have a history of withdrawal seizures, mostly recently 1 month ago, assessed today at 10 a.m., last drink reported at 4 a.m., CWAL was already 16. I like to put, in case the emergency department clinician doesn't know exactly what you're hoping will happen when they go in, requires loading doses for benzodiazepines or required high doses of benzodiazepines in the upfront, something that can kind of trigger them to what kind of care you're expecting by sending this patient in, not just a, why are you sending them here? If you are not comfortable writing that on a form to the emergency department, use the Medify guides that are already there. For example, the approach to emergency department patients for alcohol-related presentations has an algorithm that breaks it down for ED clinicians exactly of who needs higher dosing, what timing do they need it, and who doesn't need this, and who can go home. So that will kind of help guide them as well. And you're not having to say it, which is nice. Considerations for the emergency department before someone is discharged. Two main things that we really hope that they've accomplished are, have they addressed or have they prevented complications like seizures and delirium tremens from happening? A lot of the time that can be managed with high dosing up front, so either loading dosing or appropriate symptom-triggered dosing if that's really happening every hour. And is the withdrawal fully resolved? So meaning we do want that CWA at least lower than 10 at least 2 times in a row before they're going anywhere else. I know that this has been spoken about, but if mild withdrawal is lingering, a lot of people have concerns about, do I give more benzos? Do I give gabapentin? How do I consider this if I'm sending someone home, or where are they going? So if you are thinking of a home prescription, does someone actually have a safe space that they're going to? Do they have their own area that they can go to, whether it's a shelter or their own place? Are they going to a withdrawal management facility where the prescriptions could be faxed over? You don't actually have to give the patient anything personally. Do they have a support person with them? Do they have access to a pharmacy? Big one in terms of hours. If you're discharging someone in the middle of the night and you're in a rural or remote area, they're not going to have access to the medications for quite a few hours, something to keep in mind. Other options, if you're more hesitant for whatever reason about giving the patient large doses of a medication or a larger prescription, you have control of your prescriptions if you're writing it. You can do a daily dispense, you can do a blister pack, you can have it dispensed to a support person, and you can do shorter prescriptions. Typically, the recommendation is only for 2 to 3 days of continued prescriptions for alcohol withdrawal management in the community. And do they have ongoing access to care in the community, whether it's their primary care clinician or an addictions provider? More examples of what you could just find on the website if you needed it. These are discharge prescription templates. Please copy and paste them, change them if you want to, use them so you don't have to reinvent the wheel. Anti-craving medications. So very important, anti-craving medication should be routinely offered to all clients, even those that are in the emergency department. Anti-craving medications have been shown to improve drinking outcomes and reduce healthcare utilizations. In an observational study, patients who were started on naltrexone, acamprosate, or even disulfiram on discharge from the hospital had a 50% reduction in return visits to the hospital. That's pretty huge by just offering someone a medication. Again, if you are not sure about the anti-craving medications at all, there's a nice algorithm and breakdown of all the pros and cons and what to choose and why for the patient's health concerns. Really quickly, I know a lot of you already know this, probably everyone already knows this. Naltrexone helps to block the release of dopamine when alcohol is consumed or thought of in terms of triggers or cues, which reduces cravings and reduces the frequency and intensity of binges. It's contraindicated for those that are on or actively using opioids, would be the biggest one. Typically, it's just one pill, 50 milligrams once a day. Acamprosate reduces the sub or post-acute withdrawal symptoms, so things like insomnia or dysphoria or those ongoing lingering cravings. So someone that's already has the goal of abstinence or has already achieved it by a day or two is a good time to start it. It tends to extend that length of abstinence for that patient. Weird dosing of a medication, 333 milligrams, 2 tabs, 3 times a day. And gabapentin, while off-label, can be very effective for clients that you're trying to minimize the benzo use, reduces both acute and that sub or post-acute withdrawal symptoms, decreases the heavy drinking days, decreases the return to drinking as well, and has potential benefits in comorbid anxiety, insomnia, even cannabis and pain use, or cannabis use and pain. The dosing varies completely in terms of gabapentin, but a typical starting dose, which would be more than appropriate for the emergency department, is 300 milligrams 3 times a day. Quick little add-in for naltrexone, because there is so much concern in terms of the liver. We do hope that emergency departments take it upon themselves to do the blood work because they have access to it, because these clients don't like to follow up and get blood work done a lot, and it can be very difficult to get in the community. So if they're just sitting there waiting for potentially long periods of time, ordering the blood work would be fantastic so that it's on their record. But if blood work is not happening, it's not possible whatsoever, just a cue for naltrexone in the liver. Yes, the naltrexone can cause increases in the liver transaminases at typically really high doses of like 300 milligrams, more than double what the typical high dose for naltrexone would be. But we also know it can decrease those levels by reducing drinking. This is a really fun study that I love. Thompson et al. Just came out this year. So they actually put close to 3,000 patients that have cirrhosis on naltrexone and then did follow-up. And they did see liver transaminases did increase 5 times greater than baseline in about, I think it says 60 patients or so out of the 3,000. But from those ones that did have the increases, there were 0 liver injuries that were reported in those cases. So this is a very safe medication. Even in patients for both acamprosate and naltrexone, there's decreased mortality even in patients that have cirrhosis. So if you're considering, can I give this? Probably yes. Someone else can follow up with it afterwards if it's the most appropriate medication or needs to be adjusted. Last thing, hopefully we have time, building relationships and sharing resources. Hugely important for you to do the work, honestly, to make the connections with the emergency department, or if you are that emerge clinician. There are now peer support workers in the emerge, social workers, addiction consult teams, which are growing across Canada, and community outreach teams that can all be consulted at triage as soon as the patient shows up to the emergency department, or even before they get in. If you have a relationship with a peer support worker in the hospital, give them a call and let them know that this client is coming in. They'll have a nice warm handoff to someone else in a scary position for them. From a randomized control trial, peer workers and counselors stationed in the EDs are effective in connecting patients to community treatment. Should be no surprise. Connect the patient to community addiction clinics, preferably within a week of discharge. From case-controlled studies, patients with alcohol use disorder who attend a RAM clinic have decreased ED visits. Again, that shouldn't be a huge surprise, but good to know. Just more examples of discharge templates if you need one from or to the emergency department. Last thing is, does the emergency department know who you are? Hopefully you've done the work in your clinic. Someone in your clinic has called them to say, hi, I'm here. You may not be able to get in touch with every clinician that's there. A good tip is to ask for the educators. The educators typically have time built in to make these connections, and they're the ones that are educating all of the staff. There's usually a physician or prescriber educator and a nursing educator at least. So you can make those connections. You can fax them, you can call them, you can give them pamphlets or handouts or whatever you need to, so these relationships can actually be built. Ensure that you're accessible. So are you available to these clients through your typical office hours? But I would say even more in terms of supporting the emergency department, what can you do to be available to these patients by phone or through telemedicine when they're coming and going from the emergency department? Not saying you need to jump into that field of practice if that's not your area, if you're more in person, but just for these connections, can that be something that can help the client while they're there? Supporting an ED champion, someone like Elizabeth who really is passionate about addiction medicine or substance-based care. It can be any staff. It does not have to be a prescriber. It doesn't even have to be a nurse. But if you are the outpatient addiction clinician, how can you support some kind of champion in the emergency department? Can you mentor them? Can they shadow you? Can you give them your cell phone so that they could text you if you have any questions in the moment, which can be very helpful? And make it easy. We have lots of resources. All of us have pointed it out. Sorry about that, but there are tons, so you don't have to remake the wheel, basically. So we'll pause there. Hopefully we still have time for questions. Thank you all so much. This is the QR for the Medify website altogether. And our admin, thank you, Lori. Email is there if you need to get in touch with anyone. Thank you so much.
I think we're supposed to have a microphone for questions. And if we don't, speak loudly because this is being recorded. Louisa.
You know I don't like controversy. So as an ER doc, I recently quit, but I just wanted to make a couple comments. So don't throw stuff at me. This is just food for thought. But I think we have to shift our thoughts sometimes about how we're having discussions in the emerge for people who come in acutely withdrawals. And I always think there's sort of the three patients that walk into our emerge or walk into our clinic. There's the patient who's acutely in withdrawals for whatever reason. They didn't have access to their drugs. They just received Narcan by a bystander and they come in. There's the patient who comes in who isn't in withdrawals, who's saying, today's my day, I want to quit. I need a medication to quit. And then there's the third person who's medically unwell, who comes in, really doesn't know if they want to quit or not. They come in with a pneumonia, they might be being admitted. What scares me is when we make comments like, if we're going to treat them, we have to explain to them that we're putting them on a treatment, that we have to ensure they have follow-up and make sure, because we don't need to have that discussion in an emergency room. Suboxone or methadone, these are life-saving treatments. So when someone comes into my emerge and they can't breathe because of COPD exacerbation, I don't say to them before Ventolin, can I give you this? This is going to help you breathe right now. But if you don't take it, I think of Suboxone as a life-saving medication. It is not a commitment to a treatment. So when I'm giving someone Suboxone in that moment in emerge, when I know their risk of death, and we know this because all the data came out that 1 in 4 people, or 6% of people we see in our emerge who leave die within 2 days. 2 days. 6% of people we see emerge. That really at that time, can they make the decision to say, I'm committing to a treatment right now? They can't because they're so unwell and sick. So the way I look at it is at that time, when someone comes in very sick and I have to give them a life-saving medication, like I would TNK for a STEMI, I don't have this long discussion when someone's having a STEMI. By the way, this is going to say, do you want it? I give them the treatment and then I have a discussion. And many times after I've provided that treatment, and the four main things Suboxone does in the emerge is, number one, it treats cravings, it treats withdrawals, it protects them from overdose, and it reduces return ER visits. We know those four things for sure. So when I provide that treatment at that moment and they feel better, then I have a discussion. What would you like to do? Do you want to stay on Suboxone? Do you want to go to methadone? Would you like slow release? Treating them at that moment doesn't mean they're committing to anything. We're making them feel better. And I think, because I think of my colleagues who are still very resistant to this, and you know in the emerge, all of us here are not resistant to doing this in our emerge. It's my colleagues who over and over think they're not worth being treated. So if I can say to them very basically, just give them the Suboxone, in 15 minutes they will feel better, then you can have an honest discussion with them, rather than saying to my colleague, you know, you got to have this talk. Do you want to stay on this medication? You have to follow up. I don't do that with any other emergent drug in the emerge. But for some reason, our own biases is telling us we have to have this discussion for this life-saving medication. Anyways, that's my discussion about Suboxone, if that's okay. And the alcohol one, this is my thought about emerge. You know when we always had I have about 12 patients who regularly come in alcohol withdrawal. You probably have those too. And they come in and every emerge doc's like, oh, they're back again. And you know, sometimes like I've given them 400 milligrams of diazepam. Sometimes I've pushed 40 milligrams, Q15 minutes of diazepam. And it's the same thing we do every time for these patients. They stay in our emerge for way too long. So what I'm doing now, it's a bit ballsy, but we're just going straight to phenobarb. So for those patients that are highly resistant, who we know we're going to need every time 300-400, in the last month, we've been starting in our emerge, just giving them a loading dose of phenobarb. But they're very predictable patients. These are the ones that know. And I just was throwing it out there because I think it's going to be better for those patients who we know are already resistant to diazepam. Just my thoughts.
So thank you, Louisa. It's nice to see you in real life. I've never seen you in 3D. Like, this is really exciting to me. We've been on lots of meetings together. It's really nice to see you. So a couple of things. For sure about the Suboxone piece. I think the difficult piece with Suboxone is you don't have a COPD patient who is like morally opposed to prednisone. But whereas you can have, I find some of my patients who use substances really are against taking buprenorphine, and they really don't want it. So I do have the conversation. I'm going to give this to you to make you feel better. You don't need to stay on it necessarily. But I of course tell them, well, they know what it is, but I tell them upfront. And I think certainly you and other colleagues have used Sublocade like immediately. And I know that that's being done in some of our pediatric populations in Ottawa. So there's lots of other things that can be done, but I agree. I think explaining to our colleagues that this is not that scary, it's just a treatment for like we would treat anything else, I think is a really, really good point. I think it does, because there are these preconceived notions, not just in the prescribers, but in our patients about what this medication means. Sometimes it takes more of a conversation than Ventolin. Is my experience. But I agree with what you said, and I agree with those three types of patients. I think is really a smart way to think about that. And you can tell you're a community emerge doc because you're like, we have the same patients who come in with alcohol withdrawal all the time. If you work in the community, sometimes we've turned into like stand-in family doctors for a lot of patients who have no other access to care, and we see these patients over and over. So those phenobarb patients would be what Mel was talking about, the severe withdrawal patients. Those aren't the moderate, like the middle ground patients where I don't think we should be prescribing phenobarb. You also clearly follow the emerge literature, and there's a lot of talk about phenobarb. I think we just need to take a step back and look at who we're using it for, and it sounds like you're doing exactly what I'm doing, which makes me feel better about myself.
Questions? Yeah, one and then two. Yep.
Okay, so,
Just be loud, please, if you can.
yes. So I think it was a really important piece when we say, how do we communicate better, collaborate better. make it time efficient for ER doctors, for RAM staff as well. So there was good points listed, what RAM can do to make it easier communication. But I wonder if there is a standard of care when you discharge somebody, when you induct somebody on Suboxone and you discharge them to RAM. So our RAM operates like from 8:30 to 6:30 some days, so 5 days a week, even on the weekend there's an hour can be called. But so we are accessible, and so sometimes patients will be discharged from emerge, inducted on whatever daily dose of 12 milligrams or whatever that was, and they come either the same day or next day. But the challenge for RAM is, I wonder if there's a standard of care, or it could be implemented, where if you discharge or you induct, there's a sheet of paper what exactly was done, because sometimes they show up 3 days later, and we have no idea, do we reinduct it, and it takes a lot of your time, because we're going to be calling for a lot of RAM staff then, sometimes it's hard to even get in touch with anybody, and they transfer you to that unit and that unit, and yeah.
I think that's ideal, right? And that's like to as an emergency doctor, I'm discharging 25 or 30 people to a variety of different places. And so that's certainly the ideal. I think this speaks to the need for a champion in Emerge. So the question was, is there a standard of care for when you discharge a patient? So if we discharge a patient from the emergency department back to a RAM clinic or addiction medicine clinic, or if you discharge an inpatient, is there a standard of care for communication? I think there are a number of tricky spots there, but I think this speaks to the need for a champion. So if you work in a RAM that provides care to patients in a certain catchment that has 3 emergency departments, maybe you go and speak to their educators, speak to their chief. Here's an easy discharge piece that we can build into your EMR. One of our colleagues who used to work at Lake Ridge had built this all into Epic, so it was really easy. So that's something that I think we can build together. I think having staff access Connecting Ontario when a new patient comes in is really helpful for those of us who are in Ontario, which I don't think is the center of the universe. But access your provincial networks, access those electronic records that you can before the clinician sees the patient, to say, oh, hey, look, I see an Emerge visit. Here's all this blood work. Here's an ECG that we don't need to repeat. Here are all these things. So building processes into the RAM clinic, but then also into Emerge, which requires communication, I think, for sure. Because it is frustrating when you have someone show up and they tell you what's been done and what isn't. The other thing I forgot to say is, if you're an emergency physician and you're discharging someone with a prescription for buprenorphine, make sure that you know what pharmacy they're going to, or that the pharmacy is capable of dosing the buprenorphine. My husband's a pharmacist. He's very smart. Not all pharmacies are equipped to split tablets in half to do the things that need to be done with buprenorphine. So make sure that you know where that prescription is going. Have a conversation with a pharmacist. All of this is just like basic Med 1 interpersonal communication, right? That sometimes I think we forget as the healthcare system's on fire around us. We forget to do these basic things.
I think there is actually a discharge information sheet that's part of the ED-OUD toolkit that is a summary. The recommendation is to give a copy to the patient and to fax it to the RAM that describes exactly what the person got, how many days of medication and what doses. The other thing I would say, maybe we'll, after the next question, see if there's discussion, does the person really need to be discharged with a prescription for daily observed dosing at the pharmacy? Or could we just discharge them with a prescription for a week's worth of medication, right? I see some thumbs up, some nods. Why are we making it more complicated for people to stay on this therapy that we've just identified as being so critical? How much can go wrong with that week's worth of medication? And then in terms of microdosing, again, speaks to some of the challenges, but blister pack, so people don't have to think about their quarters and halves and 1.5s if that's something that you're doing. Yes.
Value of how we treat folks. And so questioning just where are we at with respect to standards of care and core competencies with the Royal College, with CFPC, in terms of examining our residents, going through, etc. I mean, I think that we need to be there when we talk about treating asthma and MI, etc.
Maybe just
Yeah.
repeat the question.
Yeah, what a great question. That's a terrific question. So for the people in the back, the question is, if emergency physicians and providers should be doing this. Why are we not? Where are we at in medical education with these pieces? So I'm also an examiner for the CCFP-EM exam, and my main education role is with paramedics. What's really interesting is we've now implemented buprenorphine initiation in pre-hospital settings in much of Ontario, which is really exciting and interesting. And I've watched that breakdown of stigma over the last few years. With emergency physicians, and like this isn't studied, this is my sense, is it's not that certainly there's stigma and certainly there's frustration. But I think a lot of it is I don't know what to do with that patient, so I'm going to complain about it because I don't know how to treat that patient. When my colleagues who've initiated someone on buprenorphine see how effective it is, and then I try to feed back how well patients have done, that's incredibly satisfying, and then they know what to do. So providing them with a toolkit, which is one reason I like to be involved in Medify, for lots of reasons I like to be involved in Medify, is providing emergency physicians whose brains are full, like we have to know all the things all the time, providing them with a toolkit of, do these things, I think is really satisfying for the clinician as well. And it helps to break down that stigma. Because when a patient is feeling better, it's easier to engage them in care. I don't know if Louisa feels the same, but I feel like giving my colleagues a tool for how to do this is really helpful. In terms of where we're at with Royal College and the CCFP in terms of where this lies on the spectrum of the emergency care and emergency education, it's coming, but it's still not, I think, where it needs to be, especially where, and the reason I led with these organizations say we should be doing this. Our national organization says we should be doing this, and residents still don't get the training to do it.
Yeah, I just want to add that in Ontario, the Addiction and Mental Health Centre of Excellence, which is an arm of Ontario Health, has implemented or started to implement their integrated addiction care pathway, with the expectation over time that all emergency departments in Ontario will be able to provide addiction treatment on site with connection to low barrier clinics such as RAM clinics. And by addiction treatment on site, they specifically endorse buprenorphine, methadone, and methadone, but not SRAM, for opiate use disorder, and anti-craving medications for alcohol use disorder. So they will, these will be standards ultimately, with the expectation that emergency departments will do these things and will be provided with appropriate support, such as patient navigators and peer workers and so on, so they can get these things done.
Yes, go ahead, please, and then we'll go back there. Yeah.
I used to be an ER doc, and I wonder about how we connect patients in the emerge while they're there with outpatient resources. I know a lot of, ideally, if you had an inpatient addiction consult service, you could possibly consult the service to have them come down and initiate treatment and follow-up as an outpatient. But would there be a role, even, where there's limited access to, say, inpatient? What about like consult services? What about like a RAM clinic? I know more places are having RAM clinics. Would there be a role to, say, have someone available on call for RAM clinic to come down and see patients in the emerge and help to facilitate discharge and follow-up? Because I think there's this critical time where you see the patient in the ER and discharge them, and they may have follow-up in the RAM clinic, but they may not be for several days. You just don't know, depending on access. So having someone in the from the clinic connected with the patient before their discharge from the ER, I wonder if there would be a role for that. Thanks.
This is a Katie question.
Sure. So the question was about, thanks. There was a question about connecting to outpatient clinics connecting to the client while they're still in the emergency department before they've discharged or before they're even admitted potentially to the hospital. Yes, it should absolutely be a thing. I guess up front, I would say I hope that these partnerships, if you're reaching out to your emergency department asking for them to do this, you do need to be willing to do something for them in return. And that is such a great suggestion of, can you be available to them when they need you? If you're sending them the client, we all know that the expectation is Emerge can't say no. You have to see these emergent cases. Can the outpatient clinic say no? Shouldn't you make yourself available to them as well in response and return? So finding some way that that communication can be both directions would be fabulous. And then my personal experience with it, I'm very spoiled, and I do recognize that up front, but I get to work on a virtual service, which here is the digital front door service. Not everyone has that, but you could use any virtual service or telephone and make yourself available to the clients that are in the emergency department. So we have peer support workers. It doesn't have to be a peer support worker, but I happen to love them. They are fantastic, and they're placed in our local hospitals. They work for our organization, our local organization, so they know us personally. So when they are flagged for anyone having a substance-related concern in the hospital or in the emergency department, they immediately mention us. And if the client wants to, they're immediately put on screen with us before they leave the hospital. I have so many conversations with patients now that are in their hospital bed, in the parking lot of the hospital, wherever they want to be, even if it's just a hello, did you know we exist? These are our hours and this is what we can do. Sometimes they don't want to start treatment right away, and sometimes they do. So it's a really beautiful way that we can make that connection. And not that COVID was amazing, but there were definite benefits to healthcare that changed along the way, and telemedicine was absolutely one of them. It's increasingly utilized, and I would encourage everyone to look at that as an option for providing care to clients that are in the emergency department or in the hospital if your addiction clinic isn't associated with the hospital as easily. Yeah.
I just want to say this is an incredibly important point. There was an article in CMHA that found that only 5% of patients who were in hospital with an opiate use disorder were received a prescription for opiate agonist treatment within 7 days of discharge. And there was another controlled trial in the States which compared social workers to peer workers in connecting people to opiate agonist treatment. And they found that for both groups, peer workers and social workers, 25% of the patients were connected to OAT and on it within 30 days. So that shows that having an addiction service, whether it's a peer worker or social worker, plus, of course, medical support, is absolutely critical in connecting patients to treatment.
There's a question back there. Hi.
Question about the house. I think we emphasize a lot about house, but I'm wondering if in a immense setting, the sounds, the subjective withdrawal still from the patient's perspective, if there might be an advantage in bringing clinician time so the patient can do it. Then I don't know if there are any pros and cons to that.
What a great question. So the question was using sows versus cows in the emergency department. That's a great question. So for me, when I see a patient in Emerge, I'm just like, are you in withdrawal? Like, because I find that I have been doing this now for a long time. I feel like I can get a good sense, but then I will document some of the cows, of course, right? But I find the cows more useful for comfort for my allied staff that I work with. So if I have a patient who's in our busy cubicles area, they're sitting in a chair, I've asked the nurse, if the cows is this, can you please give them more buprenorphine? I find that is more reassuring to the allied staff, that it's something objective that they're doing. But I think that's a really good question. And I think it's something, especially, do you work in a single covered place with like 2 nurses, right? Right. Yeah, been there, man. Like 10 years of nights, 80 kilometers from Ottawa, 2 nurses, just me. I get it. That is not easy work. So kudos to you, because I'm not doing that anymore. I've defected to the city. But that's hard work. And if you have 2 nurses and you're expecting them to do this, then maybe you could start to think about implementing other things to free up your staff. It's very different for me. And I think like, man, we're lucky. We live in such a vast, interesting country, but it's so different. Like, there's emergency departments where you work, and there's emergency departments where I work. It's really different. And then I work sometimes on James Bay, where it takes me 4 flights to get there, and I'm seeing patients mostly over the computer and once a year in person. So it's really different. It's really amazing that we get to do this, but I think you need to tailor your approach to what your resources are, because if something's too labor intensive in those departments, it's not going to happen, right? Like, the nurses will be like, I cannot. There's 60 people in the waiting room. I cannot, right? I don't know if that's the experience of other people working in really rural, under-resourced settings. Yeah. Yeah. Yes. Right. So another comment is for alcohol using the shot instead of CWA if your staff are feeling overwhelmed having to go through the whole CWA. For a nurse, like, if Katie were to do the CWA, it would take her about 2 seconds because she's been doing this forever. She's really experienced. She does emerge and substance use care. She's really good at it. For a brand new nurse or a nurse who's a travel nurse into your department who maybe doesn't have familiarity, maybe that's too much. So for sure, and we talked about this in our meetings amongst the 3 of us, is sometimes these things are overwhelming for nurses. So yeah, for sure. Yeah, totally. Yeah. Oh, sorry. Go ahead.
Thank you for the presentation. Very well done. My question is, you mentioned low barrier referral clinics afterwards. What is your definition of low barrier clinic, and what is the difference in all the ramp clinics? Because every ramp clinic seems
Well, you could come to the talk this afternoon about RAM clinics, like easy. I think this is a tricky and nuanced area. I'm going to let Jennifer and Katie take that question. But I mean, low barriers just make it as easy as possible for the patient. What I say is, I want this to fit in your life, not the other way around.
I would say, I mean, I know there's lots of sessions to be in, but we'll be talking about RAM this afternoon. But to me, to all of us, I think of the Medify team, low barrier means you don't need a referral. The clinic should have appointments, or it should have hours that people can just drop in. So they don't need to pre-book an appointment. And ideally, that drop in should have options for both in-person and virtual visits. There are lots of other sort of nuances. There is no standard expectation around the number of hours or specific days per week, but the target is that people could access care within a maximum of 3 days from the time that they were in an emergency hospital department discharge or decide that they want care. Would the ideal be every day of the week and multiple hours, including weekends and after hours? That would be phenomenal. But looking at the realities of the sort of resources that clinics have to look at, that's not an expectation for now. So no referral, no pre-booked appointment, which means people can drop in, and that at that first appointment, they can get access to both psychosocial supports and medications if appropriate. It's not a multi-stage process where they have to come in for an assessment and then come back for a second assessment and then, wait to see someone who can prescribe them. So at the sort of most general term, that's it. So, I was going to say it's 12. It's actually a couple minutes to 12. If there are any other questions, I would really welcome people to come chat with the whole team. Maybe our team can stand up. I should have done that at the beginning. I know you're going to want to say no, but the Medify core team, so you can see people, say hello when you're coming around, is obviously Mel Cahan and Katie Dunham. And then sitting here, Lori, who is our amazing coordinator who answers all of the emails if you ever reach out. Sarah Clark, who's our knowledge broker and translator, and Kate Hardy, who's our Medify Network Director. So we will be in the large room. We'll be back here in the afternoon. There are lots of materials. If there was an issue with the QR code on one of the presentations, we'll be correcting that. But all of the materials that are already out have QR codes and ways to access the whole list of resources. See you later.